I just finished in the operator room, so got the time to connect the video. 1 second that I have the problem with the PowerPoint, so I am preparing the PDF in order to prepare the lecture, because there is a mismatch between the keynote and the PowerPoint. So in 1 second, I save the presentation and I can share the monitor. Only second that I'm working with two computers. Okay.
For this time, if we have some question from the participant of some comment in the wrong diagnosis. It's a pertinent subject. Low back pain and leg pain and the wrong diagnosis is a pertinent subject and is frequent, very frequent.
Francesco, you can share the screen.
Yeah, I'm prepared. I'm sharing the video, so
yeah, good.
I think you see my video.
Yes.
Okay, perfect. Sorry for the technical problem. So we know that back pain can originate also not only from the lumbar spine, but also the sacroiliac joint can be a source of pain. So it's quite important to know, sorry, because it's a PDF, is quite important to know what is the anatomy of these pseudo joints and to consider in the differential diagnosis. From the introduction is a complex joint connecting the sacrum to the hips to the iliac joint, and there is a complex system of muscles and ligaments that work together in order to provide stability and to connect the lumbar spine with the hip joint and have a participation in the sagittal balance. So in this presentation, we will see some key points from the anatomy, the clinical manifestation, and what are the program in the diagnostic challenges in order to try to understand when a sacroiliac joint pain must be considered and what is the treatment modalities. Sorry, okay. From an anatomical point of view, is a bony structure located in the pelvis, and is the connection between the sacrum and the iliac bone, and with a pseudo articulation with synovial joints. There is these joints have a minimal movement, usually is comprised between 2 and 4 millimeters in all the plane, and there is some gender differences between the woman, especially after pregnancy, because the ligaments become a little bit more less strong and can change due to the changes according to the pregnancy. So this is important, and there is also some hormonal effect. It's essential the role of the ligaments that have a key point in order to prevent the separation of the sacroiliac joints and the control of the pelvic movement, and the muscular and fascial support that guarantee the stabilization of this articulation. From an anatomical point of view, the shape of the sacrum and the bone provide a stability. First of all, there is a firm closure that it's like if you are considering the ancient Roman arch is the key point, the keystone that allow to share the stress and the forces and that provide a stabilization with the joint. Then there is a post closure that work together with the hip and the bipedal adaptation according to the standing position and the control of the upper trunk. So it's a complex part of connection between the leg and the column. And in this way, you can understand how it's a key point. Obviously, during the lifetime of a people, there is some changes during the correlated with the age, especially in early adult and puberty. There is some changes, and then with the 60 and to 80 decades, there is a restriction of motion due to the degenerative changes that can affect all the articular plane and also this one. Obviously, the degeneration can reduce the thickening of the cartilage, the sacral and the iliac cartilage, and this provide a less adaptation of this joint and have can reflex to the spine, to the lumbar spine, and to the hip. This alteration can have a distress and abnormal motion and malalignment according to a stressful of the synovial part of the joints that is rich innervated, so there is a font of the pain. An hypermobility or a hypomobility both can be correlated with the distress, dysfunction, and pain, and so on. Also the mechanical injury. So in case of trauma and of fracture, there is an activation of the nociceptor and that are found in the capsule, in the ligaments, and also in the muscle that can provide the source of our pain. Again, we can see some picture where this is indicated in the yellow line, the articular joints, where the alteration of the anatomy can provide some dysfunction. And some predisposing factors are from a biomechanical point of view. So a discrepancy of leg length, scoliosis, gait abnormalities, and pathologies can create distress of these joints. We have mentioned several times the role of the pregnancy, because the stress, the biomechanical stress, provide a further work in this area, and there is also an adaptation of the sagittal alignment of the pregnant woman due to the pregnancy. So, and as well, spine surgery can affect this articulation. It's well known that lumbar fixation can stress also this joint in the similar way of at the descent level pathologies. We can have a distress from this point of view. In literature, there is no differences between lumbar fixation and lumbar sacral fixation. Also, if is stress when the sacral is involved in the fixation, there is a higher degree of this problem, but there is no strict correlation and there is no statistical analysis, but there are no very precise study regarding this point. Obviously, the trauma, motor vehicle collision, falls, and repetitive stress, for instance, like the running for a long distance. So for the marathonite, there is a chronic stress that can provide pain in this region. What is the prevalence? The problem of the lumbar pain due to the sacroiliac joint is quite important, because we can find that is affected. 14% of the cases of back pain is due to the sacral joint fracture joint, so it's quite relevant. And the prevalence is around 15 to 40%, so is quite important. So it's more common respect usually as the clinicians consider. So we have to think about this. The pain usually can be referred also in anterior part, so sometimes goes in differential diagnosis with appendicitis, ovarian issue, and pelvic inflammatory disease due to the irradiation of the pain. So it's quite to think, it's important to think about also this aspect. I explained before that the previous spinal fixation may affect these clinical symptoms and is considered between the 40 and 20 and 75% in a 5 years of follow-up. So it's quite important. As I said, there is no strict correlation between only lumbar or lumbar sacral fixation. Also, if it's quite intuitive that when the sacrum is involved, can be stressed a little bit more in a higher percentage the sacroiliac junction. What are the symptoms, the specific symptoms? So usually is a pain, a back pain, but there is a correlation in a leg. Usually is unilateral below L5, like radicular irradiation. Often is distal or middle to the posterior superior of the iliac spine. Sometimes can be confused with a radicular pain. Also, if it's less precise in the description of from the patients. Sorry, aggravating factors and indicators that must be considered is that the pain is worsened with activities like standing, the changing position between sitting and standing, running, as I explained before, climbing, due to the axial compression of these joints. So is quite common in athletes, in a very important athlete due to the micro trauma, and reflex are considered insidious pains with weight loss and nut sweats, morning stiffness and pain relief with exercise, and symptoms above L5 suggest non-sacroiliac joint origin. So this aspect must be considered in order to think also to other things. Regarding the clinical examination, it's not easy to define this syndrome, but is during the physical examining, the direct palpation often have evocated pain. Neurological muscular strengths usually are normal, so neurological examination is not meant to define these pathologies. And it's very important, if you think about this, to consider the leg length and the balance of the basinum. Sorry. Some provocation test, the Faber test is the most important, the most common used. So there is a flexion, abduction, and external rotation of the leg with a contralateral pelvic stabilization. But to make a more precise diagnosis, we need at least 3 positive tests in order to have 77 to 87% of sensitivity. So the other tests are the Ganless test, the distraction test, the thick thrust, and the compression test. So here you can see and find it. So we need at least 3 tests in order to consider this syndrome. Regarding the imaging, obviously MRI and the CT scan are useful to see this junction and to see if there is some edema, especially with the MRI around the bone of the sacrum and the iliac bone, to define if there is no other lumbar pathologies in order to make differential diagnosis. The bone spectra CT can define the metabolic activity and define the pain source, but is not specific for this syndrome. The radiography usually can show the degeneration of the joints, and we can define also the alignment of the pelvis. And if it's a full X-ray, we can also check the sagittal and coronal plane, and to define if there is some dysmetry of the legs. Obviously, one of the most diagnostic tests is the image-guided block with some anesthetic and steroids, and usually a decrease of more than 75% of the pain confirm the diagnosis. So is a procedure, and is an invasive procedure that can help in the diagnosis. Obviously, there is some limitation in this test because there is sometimes an inconsistent response due to the anesthetic diffusion, and we must be sure regarding the position. So it's essential to perform with image guided. Usually, there is some authors that use echography. Better is radiography. There is some other that perform with a CT scan. So we can both use all these things. The other differential diagnoses are here present, maybe tumor, maybe pudendal nerve irritation, lumbar facet syndrome, lumbar disc herniation. So we have different pathologies, but we have to think about the localization of the pain that usually is around L5. So if the radicular pain is considered for the crural nerve, we can not to think about this syndrome. Sorry. Regarding the treatment, usually must be considered the conservative treatment. Usually is initially is a physical therapy. Non-SAID, non-steroid pharma drugs can help for the pain relief. Assistant devices and sacroiliac belts may help in order to reduce the stress, the biomechanical stress, and some lifestyle adjustment obviously helps, like the weight maintenance, exercise, a correct posture, and a correction of the core. So strength of the abdominal muscle can help in order to have the compensation between from the muscular part. Education on self-lifting technique and maintaining of the proper posture, it's essential for all the back pain, not only from the sacroiliac joints. Advanced non-surgical intervention consider injection again and nerve blocks, so we can repeat also for a therapeutic point of view. In order to have a longer effect, there is also the role of radiofrequency ablation that can offer intermediate relief between 4 to 12 months, in some cases more longer. Again, the efficacy of the injection usually are mainly for the diagnostic test, while have a limited long-term evidence due to the widespread of the drugs. From a surgical point of view, when there is a failure of the conservative treatment and there is a good diagnostic test, infiltrative test, an open sacroiliac joint fixation arthrodesis can be performed. You can see here two different types of arthrodesis tools that have, but however, have a complication rate between 6 to 25%. So the selection of the patient is very important. Now there are also minimal invasive sacroiliac joint fixation. So the preferred method using lateral, transgluteal, or posterior approaches can be selected according to the knowledge of the surgeon. Obviously, the benefit is to raise the lower pain scores and reduce the disability and reduce the use of opioid drugs. So this is the main. The triangular titanium implants have improved the quality of the life because it's correlated with a reduced risk according to the shape of these devices. Other surgical techniques, there is a percutaneous screw fixation. Here we can see some techniques proposed from the our site. So there is also the sacral halar iliac strip technique. So every technique where there is a screw that blocks these joints help in the blocking and providing a fusion to reduce the movement and then the source of the pain. Regarding an algorithm in order to help, here in this paper proposed by Pawlowski, they propose an algorithm for diagnosis and treatment and allow to help in this differential diagnosis to have an help in order of the timing of the conservative treatment, and then you can proceed according to this algorithm in order to have an improved clinical decision maker. So there is also other, but this seems the most easy and well conducted. The key recommendation for daily activities, we have to consider that for diagnosis of sacroiliac joint dysfunction is essential to use at least 3 out of the 5 positive provocation tests and have an evidence level of B. Confirmation of sacroiliac joint pain can be achieved through an image guide anesthetic block, and we have seen that have an efficacy of 25%, so have an evidence level B. Non-steroidal anti-inflammatory drugs may be beneficial as a part of a multimodal treatment approach, because we have seen that only drugs cannot solve the problem, but may be used just to manage the pain, according with the conservative and the physiotherapy in order to reduce the biomechanical stress. And again, the physical therapy exercise program and sacroiliac joint manipulation is a part of the conservative treatment, and the evidence is pretty good with a level B. So, in conclusion, we have to think about the sacroiliac joint when there is a low back pain, especially if it is unilateral in the lower part of the back pain, and if there is some pain in the leg in a relative area around L5. The risk factor is previous lumbar fixation is a key factor, so we have to think about patient after this surgery having still back pain. And the pelvic tilt and L5 incidence need further research to define it is a potential post-fixation risk. So right now we know that fixation is a risk factor, but is quite impossible to define with the data of the literature right now available what is the relevance of this technique. Physical exam and image-guided injection represent the gold standard for the diagnostic tools, and the treatment option must be at the beginning conservative with physical therapy, radiofrequency, nerve blocks, and injection, and surgery, so fixation that may be performed in minimally invasive way or in, with an open surgery may be reserved only for failure of conservative treatment and with the patient with a very high degree of pain. Thank you very much for the attention. And
thank you very much, Dr. Francesco, for your excellent and complete presentation. Now we ask the participant for a question. Is there any question for Dr. Francesco Costa? I think Dr. Mustafa has a question.
Okay, how much time we have to consider for conservative treatment? There is no universal status regarding the length of the conservative treatment. At least must be 6 to 8 weeks to consider surgery. So probably I think 3 months is more convenient due to the risk also of the surgery, but I think from 2 to 3 months is necessary in order, because you have to change a little bit the biomechanical stress, so we need time to have a good muscular correction and to educate the patient of the lifestyle changing. So I think at least it's 3 months, at least.
Mustafa, you can ask the other question orally.
Yes, Professor Zileli. Yes.
Mustafa has another question. Probably
Yes.
he can ask.
Mustafa has another question, yes.
Okay, I'm reading. So what you refer the okay, regarding the leg discrepancy, there is no minimum differences that are correlated with this syndrome. So probably must be relevant in the creating a changes in the pelvic tilt. So probably must be more than 1 centimeter, but there is no specific data regarding this. In literature, in the paper, I refer that is a key point, but there is no any correlation between the length discrepancy respect the frequency of the syndrome. So probably must be considered more than 1 centimeter, but is a personal consideration, is not a definitive data. I'm reading if there is any other question.
Another question?
One comment from Dr. Ken Yonemura is saying that sacroiliac joint pain is deep pelvic pain and there is no correlation with superficial palpation over the medial iliac crest. What do you think about this?
Yeah, it depends also from the type of the patient, because if a very thin patient, you can really evocate, so this maneuver are more effective. If the patient have a high BMI, may be very difficult because the strength that you need is more relevant. So in this case, you can consider directly the infiltration to block under the match guide in order to be sure regarding this. But obviously our tests, not all the patients are similar. This is why there is 5 different tests, and also with the changes of the leg and making a different force, you can stress a little bit this joint. So at least in some maneuver you can have some evocated pain, and if you are not sure, you can consider the diagnostic test with injection. But it's really according to the patient type with the BMI, so you have to consider also this aspect. Okay, I see there is another question for instituting event. Again, it depends from the event. Usually can be evocated for more, not a single event, except for the trauma, very important trauma, where the trauma can affect directly the joint. Obviously, if there is a fracture of the sacrum, can be considered. But for the non-important trauma is the repetition of the traumatic event, like the running. For the long running athlete, can be a fatigue stress of the joints, and can be affect the symptoms. So it's difficult to have a single movement causing the pain according if there is no direct trauma. I don't know if there is any other. I don't know if I missed some question.
I think we can skip the other speakers.
Okay.
Thank you. It was
We
great
can
talk.